Good morning. It's my great pleasure to participate in this prestigious meeting. Today we will have a lecture about the endoscopic treatment of Gerd. There is a difference between gastroesophageal reflux disease and gastroesophageal reflux? Yes, there is a huge difference. Everybody in the globe has gastroesophageal reflux, which is a normal physiologic process. This is defined as the involuntary flow of the stomach content back into the esophagus, and most of these episodes are either brief or asymptomatic. So everybody has gastroesophageal reflux. Gastroesophageal reflux disease can be defined as troublesome symptoms sufficient to impair an individual's quality of life. So the disease means that this reflux may impair the quality of life, may induce injury or complications resulting from the abnormal retrograde flow of the gastric contents into the esophagus, oropharynx, or even the respiratory system. Let's take a look at the incredible structure of the esophagus. As we can see here, the esophagus is equipped to prevent the reflux of the acid with lower esophageal sphincter with a pressure of 40 millimeter mercury, upper esophageal sphincter with a pressure of 100 millimeter mercury. We can see here the location of the LES, or the lower esophageal sphincter, below the diaphragm. We can see the esophagus joins the stomach with a special angle, which is the angle of Hess, which is specially designed to prevent the gastroesophageal reflux. So any impairment of this mechanism results in the gastroesophageal reflux disease. These patients present with either typical Gerd symptoms, and this slide is very important because it will guide us to the treatment. Patients with typical Gerd symptoms present with heartburn or regurgitation. Or they may present with atypical Gerd symptoms like asthma, cough, chest pain, hoarseness of voice, or throat clearing. If patient present with gastroesophageal reflux, so we go on to prove this disease by endoscopy. And if you do endoscopy and you have either one of two pictures, either esophagitis or Barrett's esophagus, this is a sure sign that this patient have gastroesophageal reflux disease. So if we do endoscopy and we find this picture, this is a normal esophagus. This does not exclude the presence of gastroesophageal reflux disease. If you see this picture, we go to further step. We go for pH probe. pH probe, it has two techniques, either the traditional transnasal catheter, as we can see in this picture, or the newer technique, which is called the Bravo capsule. The rationale of this technique is this capsule or this catheter is located just about 5 centimeters from the LES, and it has a sensor which records two very important events. The number of reflux episodes, how many times the acid goes up in the esophagus, so it is significant if it is more than 50 episodes per day, and the duration of the acid remains in the esophagus, which is significant if it is more than 66 minutes per day. In patients with Gerd, so what is the management? The mainstay of therapy has traditionally been medical management, including lifestyle, dietary modifications, as well as anti-acid medications. In those patients unwilling for long-term medical management or with contraindication for medication, the next step has been surgical anti-reflux procedure. So we start up with medications. If patients unwilling for long-term medications, we go for surgery. Recently, innovative advancement in therapeutic endoscopy has created numerous options for the endoscopic management of Gerd. So, to whom it should be offered surgery? Surgery should be offered for patients unwilling for long-term medical management or contraindication to treatment. This is also very important. There is a wrong knowledge about refractory Gerd, that patients not responding to medical treatment, we send them for surgery. This is not correct. Surgery should be offered for patients First, with typical Gerd symptoms, patient presented with heartburn and regurgitation, patient with abnormal 24 hours PH score, and there should be at least complete or partial response to PPI. This is the patients who will get better with surgery. Typical Gerd symptoms, abnormal pH score, and complete or at least partial response to PPI. So what happens if you don't carefully select patients for surgery? Unfortunately, if you don't select carefully these patients, most of these patients will go back to PPI within 5 years. What is done in surgery? Surgery offers both techniques. The first one, which is the standard of care, it's called laparoscopic Nissen fundoplication, and the second technique is Lennox. This is the standard of care. This is the fundoplication surgery. The esophagus is lifted, as we can see here, and then we take the fundus and wrap it around the esophagus. If you do a complete wrap, 360 degree, this is Nissen fundoplication. If the patient has weak esophageal peristalsis, then we do 270 degree wrap or a partial wrap, which is called Toupet fundoplication. The other surgical technique is the Lennox, which is esophageal sphincter augmentation by a bracelet, self-expandable magnetic beads, as we can see here, which is located at the gastroesophageal junction and can self-adjust to external forces, and its limit is used to less than 2 centimeter hiatus hernia. What is the indication of endoscopic anti-reflux therapy? First, the patient should have complete or at least partial response to medical treatment and unwilling for long-term PPI administration. Patient do not qualify or unwilling for anti-reflux surgery. So we offer endoscopic treatment to patients unwilling for long-term PPI therapy or unwilling for anti-reflux therapy, which is the standard of care. These patients should have at least no hiatus hernia or small hiatus hernia. Endoscopic treatment is offered only for patients with health classification type 1 and type 2. It should not be done in patients with health classification type 2, type 3 or 4. Let's go back to the history of anti-reflux surgery, endoscopic anti-reflux therapy. It started back in more than 40 years. Dr. Angel Czech started this technique when he injected silicone at the gastroesophageal junction. And since that, many injectables and bulking agents and several plication devices has been appeared and disappeared because of their low efficacy or unacceptable side effects. Here is an example. This is a material called Enterex injected at the muscle of the gastroesophageal junction. It was abandoned because serious side effects. In the second picture, we can see the gatekeeper, also injectable and abandoned. And the last one is called barred endocension, where there is a suture plications done at the gastroesophageal junction and also abandoned because it's low efficacy. The currently in use 3 techniques now is the radiofrequency, the endoscopic fundoplication, and we have 2 devices available in Egypt, which is called Transoral incisionless fundoplication, Isofex, endoscopic full thickness plication, Gerdex, and finally the endoscopic mucosa resection or ablation. We will go rapidly through these techniques. The first one, the strata, we were honored at Theodor Bilharz. We started this technique in more than 20 years. This is FDA approved in 2000, and over 30,000 procedures have been performed to date. The rationale of this technique is we deliver radiofrequency current to the distal esophagus. This is the catheter. It's introduced into the mouth, and when we reach the gastroesophageal junction, the balloon is inflated, and it has needles comes out to deliver the radiofrequency current to the muscles of the gastroesophageal junction. As we can see here, the catheter is introduced, the needles are deployed, and the current is delivered to the gastroesophageal junction. And this process is repeated 6 times 2 above the Z line, 2 before, and 2 at the Z line. And this radiofrequency current augment the gastroesophageal junction and finally prevent the reflux. We published at the surgical endoscopy a study in collaboration with our colleagues in Cairo University, a prospective randomized trial of sham single-dose strata and double-dose strata for the treatment of gastroesophageal reflux disease. And we conclude in this study that strata significantly reduced Gerd quality of life, reduced Gerd quality of life and use of PPI drugs, esophageal acid exposure, LES pressure, and there was significant improvement in the studied patients. The second technique is called Gerdix. This is an endoscopic full thickness plication device, has been designed to inhibit gastroesophageal reflux by placing a transmural plication near the gastroesophageal junction under direct endoscopic visualization. This is the Gerdix device, as we can see here. It's introduced and it is retroflexed in the fundus. The jaws are opened and the plications are applied, and this is a video. So the device is retroflexed in the fundus. The helix grasps full thickness of the gastric wall and then retracted, and we can see we can apply the plications. And this can be repeated for second plications. This is a real life case done at Theodor Bilharz Research Institute. As we can see, this is a patient of reflux disease, health type 2. Then the Gerdix was introduced, the jaws are opened, the helix retract the gastric wall, then closed. This is after first plications. The process is repeated, and this is the second plication, as we can see nicely here. And this is the final picture after application of 2 plications. And we can see here that the cardia is nicely closed. If you compare it to the pre-treatment picture, this is very nicely closed, and the patient significantly improved after Gerdix. The other plication technique is called transoral incisionless fundoplication, which are fasteners create circumferential serosal to serosal plications, reconstruct valves approximately 3 centimeters in length and 270 to 300 degrees in circumference, guided by the surgical principles of laparoscopic fundoplication. And this device offers that it can reduce also small-sized hiatus hernia. This is also a video about the rationale of this technique. The device is introduced, retroflexed in the fundus. Also, a helix is used to grasp the gastric wall inside the jaws of the device, and then fasteners are applied. And this is repeated until we create a valve very similar to the optimum gastroesophageal junction. Then a much easier and less costly technique appeared, going back to the rationale of anti-reflux mucosectomy, which was first introduced to treat patients with Barrett's esophagus. And they take the observation that patients who had EMR or ESD for Barrett's esophagus, they start to have less reflux. So Dr. Inouye in 2014 said, why not to do EMR or mucosectomy for patients with reflux? And this observation, he published a series about the endoscopic resection of gastric cardia mucosa is performed to reduce the opening of gastroesophageal reflux. Then in 2020, Dr. Inouye and colleagues also proposed that ablation of the gastric cardiac mucosa by argon plasma coagulation, forced mode 100 watt, has almost equal results to mucosectomy. So it started in 2014 with mucosectomy, and in 2020, to avoid the complication of mucosectomy, either bleeding or stricture, they said we can do only argon plasma coagulation. It will give us almost the same results. This is the technique of the ARMA, anti-reflux mucosal ablation. We can see here patient with health to reflux, and this is the argon plasma applied, and we can see post-operative very, very nicely the cardia is closed, and this is the picture after treatment. This is the scope retroflexed. We apply the argon plasma current. We started like 1 centimeter from the squamocolumnar junction, and it's applied in a U-shaped manner. We leave like 1 to 2 centimeter without ablation to prevent stricture. This is a real case done at Theodor also. This is the patient with HEL2, as we can see nicely. And this is the argon applied. And this is the post-operative. This is done almost 1 year after follow-up after ARMA. And we can see in retroflexion that the cardia is very nicely closed. The clinical success and safety of endoscopic therapy for different techniques ranges from 50 to 90%, with a complication rate from 0 to 13%. Conclusions: endoscopic therapy in Gerd aims to offer alternative to PPI and anti-reflux surgery in patients without significant diaphragmatic crural impairment. ARMA and new plication devices have shown promising results in initial reports, and randomized controlled trials are eagerly awaited. Careful patient selection, ongoing technical refinements, and the randomized controlled trials with long-term data are the roadmap to increase the potential use of minimally invasive anti-reflux endoscopic techniques. Thank you.